Thank you, Mr. Chairman, for allowing this bill to be heard today. Members, there's a couple people I'd like to thank as well. I'd like to thank Chairman Lambeth, Speaker Pro Tem Stevens, and Representative Adcock for being primary sponsors on this bill. I'd like to thank the bipartisan group of 31 co-sponsors that have put their name on this bill. Finally, I'd like to thank the Senate chairs of Health Policy, Chairman Heiss, Chairman Pate, and Chairman Krawick, for filing a companion bill in the Senate. The Modernizing Nursing Practice Act seeks to update and modernize the North Carolina Nursing Practice Act. Many of the sections have not been updated in over 30 years. The vast majority of this bill, members, is simply technical, clarifying and codifying language. So members, if you would indulge, I'll try to run through those codifying changes quickly. The overwhelming majorities of Section 4 through 28 simply updates definitions, including clear and accurate definitions of advanced practice registered nurses that mirror the roles of advanced practice nurses throughout the U.S. Updates board member qualifications and duties. It updates executive director qualifications and duties. Updates licensure processes to reflect that application renewals are now received electronically. Updates legal processes to better protect the public, and clarifies the manner in which public and investigatory records are maintained and disseminated. Most of those sections, to the best of my knowledge, are non-controversial. In those sections, one substantial change does occur, and that's in Section 5. In that section, we are eliminating the Joint Subcommittee for Certified Nurse Midwives and the Joint Subcommittee for Family Nurse Practitioners. These subcommittees are governed jointly by the Medical Board and the Nursing Board. They handle disciplinary issues and rule changes for the practice of nurse midwives and family nurse practitioners. In this legislation, we do eliminate the need for the subcommittees because the Nursing Board has mechanisms in place to regulate the advanced practice nurses. So let's focus on the parts of the bill now that are substantial. Section 1, page 1 of the bill establishes a clearly defined licensure process for advanced practice nursing and declares that an individual licensed by the board as an advanced practice registered nurse is within one of the following 4 roles: the nurse practitioner, the certified nurse midwife, clinical nurse specialist, certified registered nurse anesthetist. So for clarification, when we are referring to advanced practice nurses, we are referring to one of the 4 roles I just mentioned. Section 1, page 2 puts into statute what a nurse anesthetist does on a daily basis. I want to stress, we are not asking for an expansion of the scope of practice for nurse anesthetists in any of this legislation. We are not asking for them to be able to do anything that they are not currently authorized to do in North Carolina. There is a debate today on this bill, but that's not it. That is not what this legislation is about. I think it's also important to point out that in this portion of the bill, we are simply putting in the statute verbatim what is already in the North Carolina Administrative Code. There is nothing in this bill that expands the scope of practice for any advanced practice nurse. 6A and 6B on page 3 basically states that with respect to advanced practice nurses, the population focus is on one of the 6 mentioned areas. 6B states the 6 components of activities that an advanced practice nurse is authorized to do. 6C simply lays out what the main components of practice for a certified nurse midwife. Again, we are not expanding their scope, but only putting into statute what is already in code. And again, to the best of my knowledge, no controversy on 6A, 6B, or 6C. 6D on page 4 deals with the relationship between nurse anesthetists and surgeons and anesthesiologists. Members, this is the crux of the bill. Currently, the law is silent as to what exactly that relationship should be. The courts have said this is a decision for the General Assembly to decide, and that's what we're asking you to do. The Administrative Code says nurse anesthetists may perform nurse anesthesia activities in collaboration with the physician dentist, podiatrist, or other lawfully qualified healthcare provider, but may not prescribe a medical treatment regimen or make a medical diagnosis except under the supervision of a licensed physician. We are not asking to allow for a nurse anesthetist to be able to prescribe without supervision, and we are not asking for a nurse anesthetist to make a medical diagnosis. We are codifying in statute what has been in North Carolina Administrative Code for decades. How do I know this? One example, I can tell you that from my hospital, Cannon Memorial, only has nurse anesthetists on staff to administer anesthesia. This is the way, as far as I know, that it's always been in underserved areas of our state, in a lot of underserved areas. And in those cases, there has been no jeopardizing of patient safety at Cannon. They have a collaborative working relationship, but are not supervised by an anesthesiologist. And you may hear stories today of situations, but I can tell you from my perspective, this model for certified nurse anesthetists has worked in underserved areas of our state where they are the only ones providing anesthesia. Members, this legislation will end this debate, allow nurse anesthetists to continue to perform their duties as authorized by the North Carolina Administrative Code, and solidify their ability to continue to work in the most challenging areas of North Carolina. 6E states what the 8 components of practicing as a clinical nurse specialist consist of. 6F states what the 6 components of practicing as a nurse practitioner consist of. Standard language. Parts 7 and 8 explain the practice of nursing by a registered nurse and a licensed practical nurse. Standard language. Section 29 is also a crux of the bill. This also deals with supervision. Section 29 repeals the supervision requirement for certified nurse midwives and nurse practitioners. Current law is silent with regard to supervision for nurse anesthetists. However, under current law, a nurse practitioner and a certified nurse midwife is required to be supervised by a physician. Many times, this supervision agreement consists of meeting twice a year to go over charts. This provision is outdated and increases the regulatory burden and cost on nurse practitioners and midwives. These agreements have been known to cost up to $24,000 per year. Further complicating this mandate is that before they can practice in North Carolina, a nurse practitioner and a certified nurse midwife are required to find a physician who will agree to enter into that supervision agreement. This makes it even more difficult for them to practice in underserved areas of our state. Also, if a supervising physician wishes to no longer have the agreement, the nurse midwife and nurse practitioner by law are no longer allowed to practice in North Carolina if they can't find a new physician. This supervision agreement is outdated and unnecessary for modern medicine. In summary, members, in conclusion, this bill will do 5 things. It updates language to align with electronic submission of applicants and complaints, standardizes education and license qualifications, and other updating and conforming changes. Number 2, it will solidify in statute and make clear once and for all that a nurse anesthetist should work in collaboration with the physician. Number 3, it will remove the supervision requirement for certified nurse midwives and clinical nurse specialists. And nurse practitioners, It will remove the joint subcommittee for clinical nurse specialists and certified nurse midwives, as I stated earlier. This legislation will reduce, number 5, this legislation will reduce the unnecessary regulatory burden on advanced practice nurses, expand access to care in our underserved areas, reduce the cost of health care, and studies have shown, I know we can pick and choose which study we want to look at, but studies have shown that we can do this without jeopardizing the quality and safety of care. There will be a PCS to tighten up the language, but just so there's no confusion, that's what the intent of this language in this bill is trying to do. Members, on a personal note, most of you know me, and most of you know that I'm not an ideologue. And I generally do not get involved with bills that do not build consensus. There are good and honorable people on both sides of this debate, and I'm proud to call both sides my friends. In this case, however, this legislation is the right thing for North Carolina. This legislation will allow certified nurse midwives, nurse anesthetists, and family nurse practitioners to practice safely in underserved areas of our state like mine. I ask for your support today, and when the time comes, I ask for your vote on this legislation. Mr. Chair, if you would, with your indulgence, if you would recognize Chairman Lambert to speak briefly on the bill.
Chairman Lambert.
Thank you, Mr. Chairman. Just have a couple things to add. I've been asked many times, why did I sponsor this and why was I willing to take this stand? And I just want to share a couple observations with you. HB 88 does not expand the professional scope of practice in any way. To date, more than 40% of the states have adopted full practice authority, license, and practice laws for nurse practitioners. North Carolina is aging, and the demand for health care, particularly in rural North Carolina, will only increase, and we're not producing enough physicians, caregivers to meet the increased demands. Easing the regulatory restrictions will improve access to care. Let me just share with you a table on the aging numbers that I received recently from the aging committee that I serve on. And this is 2015 numbers. North Carolina's population is about 10 million. 38% of that population is over 60. Roll the clock forward 20 years, 2035, and you're all sitting here. The population of North Carolina increases to about 12 million, about 20% increase. The proportion of individuals over 60 in North Carolina is 50%. Over 85 increases 102%, over 65, 67%, and over 60, 53%. The demographics of North Carolina are changing quite dramatically. Most of the demands on health care and the dollars spent are in the latter stages of life, and certainly over 60. Currently, the majority of counties in North Carolina do not have an OBGYN physician. Many rural counties lack a psychiatrist or adequate primary care access, and it's no wonder that our infant mortality in North Carolina is one of the highest in the nation, and our mental health problems are some of the worst in the nation. 19 counties don't have an anesthesiologist, yet surgery is performed in all but one of those counties. We talk about regulatory reform in Raleigh, only when it's convenient. This law has been in place for many, many years, and healthcare has changed dramatically since then. It is time to modernize this outdated law. Let me share and read from you a policy paper from the Duke University Center for Health Policy. And this is, I'm quoting, "There is extensive empirical evidence that APRN practice outcomes are at least equivalent to those of physicians. Moreover, especially when there is a shortage of physicians, it makes little sense to further divert doctors from patient care by imposing burdensome physician supervision requirements that other states have eliminated without any empirical demonstrated adverse effects on quality of care. Less restrictive regulations of APRNs offer the prospect of providing North Carolina residents better access to care or better quality, even as the healthcare system sheds some of the avoidable costs. It is rare that a policy change often gains access all three major dimensions of healthcare." One other thing I'd leave with you is the Institute of Medicine recently came out a report on the future of nursing. Recommendation number 1 said, remove scope of practice barriers. Advanced practice registered nurses should be able to practice to the full extent of their education and training. Thank you, Mr. Chairman.
Thank you. And at this time, we'll move into the comments from the supporters and the opponents of the bill. We're going to do that first before we take questions. So we're going to start 10 minutes from the supporters, 10 minutes from the opponents, then an additional 5 minutes for the supporters and an additional 5 minutes for the opponents. And we will start with Julie George, who is the Executive Director of the North Carolina Board of Nursing.
Thank you, Mr. Chair, and thank you, Representative Dobson and Lambeth, for the opportunity to speak with you today about the need to modernize the Nursing Practice Act. I'm Julie George. I'm the Executive Director at the North Carolina Board of Nursing. I've been employed there at the Board of Nursing for 21 years, so I've been in regulation a long time. I've been the Executive Director since 2008, and I currently serve as the President-elect for the National Council of State Boards of Nursing. I'm pleased to say that North Carolina has been recognized through the years as a leader in nursing regulation. We were the first state to regulate nursing in 1903, and we're the largest occupational licensing board in North Carolina. We license almost 154,000 licensees, and of those, over 10,000 are APRNs, or advanced practice nurses. I respect your time, so I'll keep my comments brief. Our current law requires, as Representative Dobson mentioned, that nurse practitioners and nurse midwives have a written collaborative practice agreement with a physician in order to be approved to practice in this state. Around half the states are less restrictive and allow full practice authority for all APRNs. You can imagine that with military spouses moving to North Carolina, when they come here from a less restrictive state and they've possibly worked for decades to full practice authority and are told that they have to find a physician who will agree to sign an agreement with them before they can even get a job, it is certainly a deterrent. But they don't have a choice. They have to move here. Their spouse has been assigned here, so they certainly have to comply with regulations, but it's a difficult thing to explain to people who've worked for decades in a different environment. We are one of the 3 remaining states that still even have joint regulation with medicine and nursing of advanced practice nurses, and the modernization bill would serve to move us into the 21st century. There's no new language, as Representative Dobson said, and there's no expansion of the professional scope for any nurse that's done in this bill. We have decades of research, and it's not just nursing research. You can see at least some of what I brought with me. It's research that's been done by the John Locke Foundation, by the Institute of Medicine, the FTC, or Federal Trade Commission, the National Governors Association, and the North Carolina Institute for Constitutional Law. Most importantly, I think for you to know today is that of those states throughout the country that allow full practice authority, there has never been one state or one legislature that has ever rescinded that authority or gone back to impose physician supervision. You may hear today that additional supervision is needed to ensure that nurse practitioners don't over-prescribe opioids, and that is simply not supported in the literature. There's national literature, data. You can go yourself to the DEA's website for diversion control and look at data from 2000 forward. There are very few nurse practitioners listed there, and those who are listed, the vast majority, come from states that require physician supervision. You may also hear that the nurse practitioner scope is flexible and broad in North Carolina because of the physician supervision. That also is not correct. Since at least 2000, all states have required graduate education, national certification, and that determines the role and the population that those advanced practice nurses serve. Neither a physician nor an employer can expand the scope of a nurse or an advanced practice nurse. So in order for North Carolina, I believe, to fully reap the benefits of our nursing workforce, updating our regulations is essential. As you look for ways to reduce unnecessary regulation, I respectfully submit to you that modernization of the Nursing Practice Act can move us in that direction. Thank you very much.
For the remainder of the 10 minutes, Patrick Ballantyne, who is a lobbyist for the North Carolina Nurses Association and the North Carolina Association of Nurses Anesthetists. Mr. Ballantyne.
Thank you, Chairman Burr, other chairmen and members of the Health Committee. Thank you so much for allowing me to speak for a few minutes. I'm going to take the remainder of these 10 minutes and then also come back to you after some opponents' testimony and get another 5 minutes. I served in the North Carolina Senate for over 10 years. This was an issue then, and it's still an issue now. I've been dealing with this for a long time. And I just want to try to help you understand the complexities of this bill and break it down for you. Don't let fear and smear confuse you. That's what the opponents are trying to do, muddy the waters and confuse things. If you remember one word today, one word, I want it to be this: evidence. I'm going to be presenting evidence. I want you to listen to the facts and understand that unsubstantiated anecdotes do not equal 40 years of third-party research-based evidence. So why is this bill necessary in North Carolina? As the chairman and the sponsor said, this will assure quality health care, it will improve access to health care, especially in rural areas, and it will reduce overall health care costs in the private sector and also save tax dollars under Medicaid. This is a regulatory reform bill. The bill seeks to remove outdated, unnecessary, anti-competitive, and costly restrictions on advanced practice nurses. This issue of supervision has been in dispute in North Carolina for over 3 decades. There have been lawsuits and attorney general opinions and court cases and memoranda of understanding and consent orders and legislation. This is not a bill that's easy to read and understand. This bill has references to regulations and codes and cross-references, and it deals with many different statutes. It deals with 4 different advanced practice nurses. 1, the clinical nurse specialists have no statutory supervision. The certified registered nurse anesthetists have no statutory supervision from an anesthesiologist or a physician. The only statutory supervision on a CRNA is from a dentist. The certified nurse midwives and the nurse practitioners do have statutory supervision that we are trying to remove. So it's a complicated web that I'm trying to let you understand the basics. It has an inconsistency of statutes and regulations. They're not clear. The regulatory boards are in conflict, and it's the General Assembly's duty and responsibility to take this on, as a majority of other states have. I think one of the first things you need to know is supervision. What is supervision? What is the reality in North Carolina, and what is its impact? You have to determine for yourselves, is supervision really about patient safety, as the other side says, or is it about something else? I'm not going to cast aspersions as to what that something else is at this hearing. Suffice it to say, there is no compelling health care reason to oppose this bill. I present to you fact situation number 1. A nurse practitioner in rural North Carolina practices to her scope of practice all day, every day, as long as she has a written contract with a supervising physician who can be all the way across the state while she's seeing patients. An APRN has to pay that supervising physician, as you've heard, up to $20,000. The administrative code for nurse practitioners I present to you as Exhibit B. That shows that they only have to meet 1 time every 6 months. It actually says, and I quote, they have to have scheduled meetings between the primary supervision and the nurse practitioner at least every 6 months. 6 months. I didn't say 6 seconds. I didn't say 6 minutes. I said 6 months. Is that really supervision? And if you look at an advertisement that's out right now, Doctors Without Bosses, money earned from supervising good, experienced nurses or PAs is almost passive income for the doctor. Doctors can earn from $10,000 to $15,000 per nurse. So a doctor supervising 4 full-time nurses would earn up to $60,000 per year in extra income. My time is up for this segment, but I will be presenting evidence. That last ad should show you it's not just about patient safety, it's about something else.
And now we'll have 10 minutes for the opponents of the bill, and we'll start with Dr. Paul Rieker.
Thank you. My name is Dr. Robert Paul Rieker. I'm a private practice anesthesiologist from Wake County. I represent the North Carolina Society of Anesthesiologists as director and a past president. I'm here today to speak in opposition to House Bill 88 because it eliminates long-standing North Carolina law that protects patients and the public by ensuring that a physician supervises a nurse anesthetist when providing anesthesia care to patients. I work daily with nurse anesthetists providing care to patients in an anesthesia care team model. Because of my own professional career as a physician, I probably know more nurses than any other type of working professional. My own mother is a registered nurse. I love nurses. I do not intend in any way to speak out against nurses or the nursing profession. But I do have to speak against nurses practicing medicine. Despite what is being said, that House Bill 88 proposes only minor or subtle changes to the Nursing Practice Act, it would allow nurses to practice medicine without medical education, training, or licensure. This bill seeks to eliminate physician supervision of nurse anesthetists. Specifically sections 1, 6D, and 7, as referenced, omit physician supervision of nurse anesthetists while they would presumably be making medical diagnoses, medical decisions, prescribing medical treatments, and performing medical procedures. Anesthesia administration is a medical act that encompasses many aspects of patient care, from the outpatient office setting to the most advanced operating rooms. Anesthesia care can be as minimal as mild sedation for a minor procedure to full general anesthesia for patients undergoing complex surgeries of long duration. As anesthesia has advanced and become much safer over the last 50 years, people forget that potential adverse outcomes and near misses can occur any day in any clinical setting and with the most skilled anesthesia care. These adverse outcomes include things like stroke, burns, drug reactions, heart attack, blindness, brain damage, and death. Anesthesia exposes patients to risk. Physician supervision of nurse anesthetists adds patient safety and quality of care by ensuring medical responsibility during the critical perioperative period. Eliminating physician supervision of nurse anesthetists has absolutely no impact on access to care. Anesthesia is provided as part of a surgical procedure or dental procedure, and a physician, either a physician, anesthesiologist, surgeon, dentist, is always directly involved in that episode of patient care and can assume ultimate medical responsibility when seconds count. The fundamental education and training of physicians and nurses are different. I work with student nurse anesthetists often and have given several lectures at the Raleigh School of Anesthesia. My practice has served as a clinical site and supported student nurse anesthetists for decades. We're joined here today by Dr. John Blank, a local anesthesiologist and the president of the Raleigh School of Nurse Anesthesia Board of Directors. He can answer any follow-up questions for the committee members following the hearing regarding education of nurse anesthetists. Advanced practice nurses do have additional training to qualify themselves, but it is not the equivalent to medical education and training. Physicians undergo a minimum of 11 years education and residency training to develop extensive medical knowledge. Anesthesiologists undergo 12,000 to 16,000 hours of clinical training during a residency prior to their board eligibility, in contrast to a minimum of 1,700 hours for nurse anesthetists. So the training and education is different. House Bill 88 represents a radical change in North Carolina law and standards for patient care in our state. Section 1.7 eliminates the statutory basis for physician supervision. As recently as 2005, the North Carolina Court of Appeals concluded that the existing statute means that, quote, physician supervision of nurse anesthetists providing anesthesia care is a fundamental patient safety standard required by North Carolina law. The North Carolina Medical Board and previous attorneys general also concluded for decades that North Carolina law requires physicians to supervise nurse anesthetists. Every hospital in North Carolina requires physician supervision of nurse anesthetists. It's not always an anesthesiologist, but it is required that a physician supervise nurse anesthesia. Federal Medicare regulations require physician supervision of nurse anesthesia in North Carolina. There are many precedents to support and continue this important patient safety standard. In conclusion, physician supervision of nurse anesthesia has been an important and effective patient safety standard in our state. That is why the North Carolina Medical Society, the North Carolina Dental Society, and the North Carolina Hospital Association have joined the North Carolina Society of Anesthesiologists in opposing the elimination of physician supervision that is contained in House Bill 88. I urge you to oppose this bill and maintain the physician supervision of anesthesia care that has protected North Carolina patients for many decades. Thank you for your consideration.